Hello, I am Dr. España Schmidt, a hospitalist at the Danbury Hospital. I am happy to share my lecture about AV blocks. I would like to start out with some basic concepts. The natural pacemaker of the heart is the SA node. In the SA node, the electrical impulse that is going to depolarize the heart starts. The electrical impulse needs to travel to the AV node. This trip takes about 0.08 seconds. The AV node then delays the impulse up to 0.20 seconds. This accounts for what we call the PR interval. The normal PR interval measures in between 0.12 seconds to 0.20 seconds, and this is in between 3 small squares to 5 small squares. Anything beyond 0.20 seconds is considered to be a first-degree AV block. Here we have a rhythm strip with a normal PR interval. This one measures about 0.14 seconds. But sometimes we see this. It strikes my eye that the P waves are coming way before the QRS complexes. So let's try to figure out this methodically. As I always say, the first thing is to consider if the rhythm is sinus. So let's say there is a P before every QRS, yes. Then the RR intervals appear to be constant. Then the axis of the P, we can determine that looking if the P is positive in 1, positive 2, and negative in VR. And that rule is accomplished here. Then we need to figure out the heart rate. So the heart rate, if we use the 300 rules, and we count the biggest squares in between the RR intervals or the QRS, we can find 5 big squares. Using the 300 rule, this is 300 for the first, 150 for the second, 100 for the third, 75 for the fourth, and 60 for the fifth. So the heart rate is about 58. This patient has sinus bradycardia. Then we need to measure the PR interval. The PR interval is obviously enlarged and is about 7 small squares, or 0.28 seconds. So this patient has first-degree AV block. So first-degree AV block is an increase of the time in between the beginning of the P to the beginning of the QRS. How much? More than 0.20 seconds. But is first degree always benign? Well, it depends. Most of the time it is. However, sometimes you can find first degree AV block associated to bundle branch morphology. In this case, it is possible that the block is not actually in the AV node, but in the His bundle or its divisions. It is rare, however, you need to be aware of this possibility. A patient with symptoms, first degree AV block, and morphology of bundle branch may require more testing. But sometimes we see this. So here it strikes my eye that there is some type of grouping of the QRSs in this rhythm strip. Because we don't have a complete EKG, we will assume this rhythm is sinus. But as you see, the PR interval here is 0.18 seconds approximately, but then increases to 0.21 seconds. and then increases again. After that, there is another P wave which is not conducting a QRS or not producing a QRS. Then the cycle starts again until a P is not conducting or drops the beat. As you can see, the PR intervals are always increasing, and it's easier to see if we put all the PR intervals one above the other or one below the other. Then this is called a Wenckebach cycle, and the name for this is Wenckebach phenomena. So this is the first Wenckebach cycle and then a second Wenckebach cycle here. The first cycle will be called as 4-3 because there is 4 P's conducting 3 QRSs, and the second one will be 3-2 because there are 3 P's conducting the QRSs. As we can see here, there are 4 P's and then there are 3 QRSs. As we can see in this Louis diagram, basically the defect resides in the AV node that is delaying the impulse more and more until it gets blocked and the cycle repeats. Here we have the original trace from Wenckebach. This is a graphic of the jugular pulse. The A waves correspond to the atrial contraction and the C waves correspond to the carotid impulse. We can see how the impulse separates from the atrial pulses of the jugular vein. The discovery led Wenckebach to propose his theory for the mechanism of this type of second-degree AV block without the help of the electrocardiogram. So now I would like to continue with the second-degree Mobitz 2 block. There is a constant PR interval and an identical PR duration before and after a cycle, and there is usually a wider QRS. Most of the time, the location is Hessian or infrahessian for the Mobitz 2 block. A high probability of evolving to a complete AV block is present more in the Mobitz 2 block and usually worsens with stress, and the Wenckebach or Mobitz 1 improves. Mobitz 2 usually improves with carotid massage, and Wenckebach usually worsens. Here we have a trace with a Mobitz 2 type block. Here we have a P before every QRS, and then suddenly we have a P that does not conduct the QRS. As we see, the QRS is wide and the PR intervals are constant. Here we illustrate with a Louis diagram what is going on. So basically, everything looks working fine except for the QRS, which is elongated, and then suddenly there is a block. But this block occurs in the Hessian and infrahessian tissues. Here we have another trace which shows a constant PR interval followed by a P which is not conducting a QRS. Now we have here a challenging scenario. Here we have a P before a QRS and then a P that drops the beat. And that happens again and again and again. So we call this a block 2-1. This is a second degree block 2-1. And it's because the cycle has 2 P's for every QRS. We can't name it Mobitz 1 or Mobitz 2 because we are not able to find if there is or not Wenckebach phenomena. The QRS, however, may give you some answers. If the QRS is wide, this is most likely an infrahessian block and is more ominous. If the QRS is normal, then it's most likely a through AV block. Then we have the high degree AV block. A high degree AV block is described when two or more successive P waves are blocked. The AV ratio is usually 3:1. There is a constant PR interval in all conducted beats. The atrial rate, of course, is greater than the ventricular rate. The clinical significance for this is comparable to the complete AV block. So we have a trace here where we can see that there are many P's, but not all the P's are followed by the QRS. Here we have a cycle, and this cycle is 3:1. This gives us the diagnosis for an advanced degree AV block. Finally, we have the third degree AV block. The third degree AV block is a complete atrioventricular block. There is a total independence between the atrial and the ventricular activity. There is what we call atrioventricular dissociation, which is the name of this independence. The ventricular pace is usually between 20 to 40 beats per minute, and it's secondary to idioventricular rhythm. Sometimes the ventricular rate can be higher in congenital forms. Here we have a third degree AV block. As we are able to see, there are many P's that are not conducting a QRS, although one may think that there is some sort of conduction. We can see that the RR intervals are very different from the PP intervals and have no mathematical correlation. This happens also down here, where we can see that the length of the RR interval has nothing to do with the length of the PP interval. As you already figured out, type 2 AV block is divided in Mobitz 1 and Mobitz 2, and the distinction is based on the presence or not of the Wenckebach phenomenon. Please like the video if you enjoyed and leave your comments. Do not hesitate to subscribe and share if you liked it. More videos coming soon. Check out my other videos. This was the AV block chapter of my EKG lectures. This is Christian España Schmidt, MD, hospitalist at the Denver Hospital, Connecticut.